My name is Beverly Chang. I am an endocrinologist and obesity medicine specialist, an assistant professor at Weill Cornell in New York, as well as an advisor for Skye Bioscience. I've been in this obesity field for over 5 years now. I have trained at Weill Cornell here in New York, as well as Columbia for both my internal medicine and endocrinology fellowships, and did an additional year of training in obesity specifically here at Weill Cornell. The landscape of obesity medicine is fresh and new for, I think, any clinician who's really dedicated to quote-unquote helping patients. And I think one nuance that we don't fully realize about medicine is that we do seem to wait until people get sick before we treat them. And I think obesity gives us a new point of intervention where if we treat this effectively, we really do prevent all other diseases and really preserve a person's health. So that is what has really drawn me into this field. I think the field of obesity medicine, as young and new as it feels for many patients, has come a long way and has a much longer way to go, of course. I would argue that our first set of anti-obesity medications really came about in the 1950s and 1960s. Some of you may be familiar with them in the form of phentermine, for example, our stimulant-type medications. But those medications were only approved for short-term use, and so many people tend to use them for 3 months. Any longer than that is considered off-label use, and while still evidence-based, there are concerns with using it for long-term just because of the lack of data that we have there. Coming into the 1990s and 2000s, we see our second generation anti-obesity medications that reached a new standard set by the FDA, actually, because the FDA was now requiring proof of both clinical efficacy and safety. Those second-generation medications like your phentermine topiramate, naltrexone bupropion, and maybe even liraglutide, the once-daily GLP-1, I would argue, are our second generations because they achieved a level of weight loss where we really started to see improvements in blood pressure, in cholesterols, in glucose levels, etc. We're on our third generation of anti-obesity medications, I would argue, because again, medications like semaglutide and tirzepatide are achieving 15 to 20% weight loss, where we are seeing complete resolution of people's diabetes, of their hypertension, of their high triglyceride levels, to the point that they can discontinue medications that were previously treating their blood pressure, for example. And I think the question now is, what is the next generation of obesity management going to look like? I think we're going to see continued evolution in the pharmacotherapy space, number one. Those agents will focus probably more on fat loss specifically and not just overall weight loss. We're going to see more of these different peripheral mechanisms that target metabolism and that energy expenditure side, not just trying to suppress appetite and reduce intake forever, but really targeting what is different, what is the quality of fat that we can change here with peripheral mechanisms. And then we will likely see a difference in obesity treatment with respect to how lifestyle modifications fit into the landscape of pharmacotherapy. Is it something that we need to start first and find that it doesn't work in order to start medication? I don't think so. I think we're going to finally realize that we should be doing both in parallel for people who seem to need those medications already. And those might be individuals with higher levels of excess weight, or those who have excess weight plus weight-related comorbidities, where we should be offering both lifestyle modifications in parallel with pharmacotherapy. There's so much research that needs to be done in the obesity space. I think a lot of people are still asking themselves, how do we really define obesity? We have ethnic-specific thresholds for some. We're recognizing that obesity is not just body mass index. It's not just weight, it's also fat mass and where that's distributed. We're trying to understand what the long-term outlook of obesity care looks like. So losing weight is one thing, but of course sustaining that weight loss is another question, and what might be the best strategies to do that. But I think actually the most pressing need we need to understand now is the use of medications, not just weight loss medications, but all medications in people with obesity. There is a significant blind spot in current research and pharmacotherapies for your over-the-counter medications, for supplements, for medications for depression, medications for blood pressure, medications that treat more other diseases, cancer, blood clots, the whole gamut of medications are classically studied in individuals of normal weight. We don't fully know what their pharmacokinetics or pharmacodynamics effects are in people with elevated weight. And when we have, again, 40% or more of people with obesity, we don't fully understand how those medications are causing side effects or not causing side effects, are achieving therapeutic efficacy in these individuals. So I do think that more research needs to be done, and there needs to be a requirement from our regulatory bodies to ask our manufacturers and researchers to make sure that the medications that are available are studied in the population it's actually used for. I think we are headed in the right direction. I think that, of course, in an ideal world, we understand the root cause of all of our diseases and that we can prevent them before they happen. And that does mean, of course, re-examining the way our society works as far as our food systems, water supply, stress levels, sleep schedules, work schedules, all of that. We need to understand better to prevent these chronic diseases that are plaguing our society. There's no reason that we can't do both, right? We can treat obesity as a disease and also invest resources in understanding why our obesity epidemic has only worsened. I think that there's so much energy already propelled by the fact that we have a medication now to treat a disease that affects 40% of Americans and that has never been treated before. This critical mass threshold has not been seen in any other medical condition before. And that means we have enough voices, I would say, to really convince the people in power, our policymakers and other stakeholders, to make a change. I think that change needs to start grassroots with us and our voices to affect our policymakers to make a top-down change. And that means prioritizing healthcare, preventative care, starting with obesity treatment. What I think people don't fully realize is obesity is just like any other feature of a person. So there's always a combination of nature plus nurture. And I think society has been wrong for many decades, pushing only the narrative that it's the nurture, the environment that can fix obesity, which means we've been ignoring all of the nature pieces of that, the genetics, the hormones, the real biology of what makes a person have black hair or straight hair or brown eyes or have an elevated weight set point, for example. And so really, I think the biology of obesity comes down to us fully recognizing now that there are many different hormonal mechanisms in our body that tell us when we're hungry, when we're full, when we're above our weight set point or below our weight set point, and it can be quite challenging for us to address all of that in today's environment. Metabolic adaptation in a sort of basic form is really the body's way of fighting our weight loss, because we have these evolutionary mechanisms that implore our body to find higher weights to be more protective. When we lose weight, those counter-regulatory mechanisms force us to increase or compel our appetite to increase or make it harder for us to feel full, or they slow down our metabolism to levels lower than what you would expect for the degree of weight that you've lost. And so these mechanisms make it difficult for us to sustain long-term weight loss over 1 year, 2 years, 5 years. And this is why when you look at the studies, many people seem to regain the majority of their weight over 5 years or so, particularly when you look at studies that use only lifestyle changes. So if you're just forcing yourself and counting calories to eat less, your body will fight back by telling you that you're hungry. And what has changed this battle has actually been pharmacotherapy, and in some cases surgery, some surgeries as well, where it changes that hormonal environment so that those counter-regulatory mechanisms that tell you that you're hungry, that slow down your metabolism, can be addressed. I think of it in terms of short-term and long-term energy. Short-term energy status is whether you're in a fed or fasted state. Have I just eaten? Am I full now? What am I going to eat next? And there are certain class of hormones or category of hormones, peptides, that control our short-term energy status. Long-term energy status, as we understand it now, is largely determined by our fat mass. In other words, if we have more fat, then we have a lot of energy stored. And so we might be preserving that higher body weight set point or that higher fat mass set point. In the research, we like to call this the lipostat. So similar to thermostat, but lipo for fat. And what we're understanding lately is that the disease of obesity is a problem with our fat mass, both in terms of quantity and quality. So the quantity of fat mass is elevated, of course, and that's something that we want to reduce because that quantity seems to be causing downstream problems. For example, excess weight on our knees and osteoarthritis from that. But the quality of it seems to differ as well, especially when you look at where that fat has accumulated. So if our fat seems to hang around our middle in our abdominal area, we know that it's associated with more inflammation and perhaps even other hormones that increase the risk of blood clots. And that type of fat is what we call visceral fat. It sits around our actual organs. It sits in our liver, it sits around our kidneys, it sits around our heart. And so you can imagine that when you have poor quality fat that increases inflammation, that increases the risk of clots sitting right around our heart, you can see how obesity can cause heart disease, heart attacks, heart failure, and other problems. And this is why we need to, as part of research, as part of the medical system, understand and better treat obesity, both in terms of that quantity problem and quality problem. Obesity treatment is more than a number on the scale. And in fact, I would say the goal of obesity treatment is not actually weight loss. I think weight loss is a beneficial consequence of treating obesity, but treating obesity really means addressing those maladaptive food relationships, the feeling that you never feel full, the feelings of hunger all the time, or the food cravings or the food noise. That is what obesity treatment is. And the fact that we lose weight is almost, again, that downstream benefit of treating obesity. And so when you speak to any patient who has had their obesity treated, weight loss is just one piece of their story. What they're really happy about is being able to walk upstairs without having to stop and pause to catch their breath. Or they're really happy about being able to pick up their grandchildren without back pain, or be able to go on long walks in the park without knee pain. All of these are actually the benefits of obesity treatment that relate more to quality of life and are far more than a number on the scale. The development of obesity management as a field has come a very, very long way, in the sense that older medications, you might see what we call a response rate of 5% or greater weight loss of maybe 50%. In other words, I prescribe one of these old medications, 1 of 2 people will actually see significant weight loss. Nowadays, with the newer agents like the incretin or GLP-1 class, we're seeing a response rate of 80 or 90%. So 9 out of 10 people will see weight loss. What we're approaching here then is perhaps a standard of care where individuals with obesity should be offered a medication which will more than likely, 90% of the time, treat their condition. However, 1 out of 10 people, while a minority, may not respond to that medication. And I think that is the space where we will really see the importance of individualized therapy. 1 out of 10 people may not respond to our standard of care, whether that be an incretin medication or an alternative medication, but those 1 out of 10 people may need combination medications, they may need a medication of a different class or mechanism, or they may need further diagnostic tools in relation to genetics, microbiome, resting energy expenditure testing, in order to better form what their medical management regimen should be. We consistently see a pattern where we see a little bit more weight loss in the clinical trials than we see in real-world practice. And I think that makes a lot of sense because the clinical trials are a little bit of a bubble. You're seeing a member of your scientific research team on a very regular basis, and we don't necessarily have the bandwidth to have that number of touch points, weekly meetings or monthly meetings, monthly appointments with our medical team in the real world. But I think that's still okay because the degree of weight loss we're achieving in real world practice is still reaching those averages of 10, 15, 20% that we need to see for comorbidity resolution. And I would say that even though we may not be seeing the same results as we see in clinical trials, clinical practice is crucial to recognizing those individual goals for each person. So if you're not seeing the degree of weight loss that you like or that you expect based on the research, it's a reason to speak with your practitioner and your team to find out what might be holding us back, what might be the challenges here that could be addressed differently, which you would not have the ability to if you were in a clinical trial. The GLP-1 revolution, I think, is called that appropriately because we are, with these medications, achieving a new threshold of obesity treatment where people are seeing a threshold of weight loss at which other weight-related conditions go away. Previously, lifestyle therapies, for example, might allow us to lose 5% of our weight, 5 or 10 pounds for the average person. And with that amount of weight loss, we can see improvements in our blood pressure or improvements in our cholesterol. But these patients may still have that condition, but maybe they're reducing their blood pressure medication dosage, but they can't stop it entirely. In contrast, now with the GLP-1s, we're seeing 10, 15, 20% weight loss thresholds where blood pressure completely normalizes and people can stop their medication entirely. And I think this reaffirms to us that excess weight is the root cause of so many of our metabolic diseases. And if we treat weight, we can really make a difference in those other consequences and prevent them entirely. All of the medications we use now for obesity management work through appetite suppression. So many patients will ask me, well, how does semaglutide work or tirzepatide work or some of the oral medications that we might use on or off label? And by and large, they cause weight loss by reducing appetite and food intake. But if you work with enough patients as I do, you'll find that we can only suppress appetite so much. And some of our patients are eating maybe only one meal a day. So we always have to ask ourselves, is this the appropriate way to lose weight? Are there other ways we can optimize this? And how do we do that? This means exploring peripheral mechanisms. So when we look at appetite suppression, that works through central mechanisms or areas in the brain that tell us when we're hungry and when we're full. But the current landscape of medications focus primarily on those central medications. None work through peripheral mechanisms. And we think that those peripheral mechanisms is what we need to really address the energy expenditure side. In other words, how does our body decide when to store the food and when to burn it? And is there a way that we can perhaps activate our fat, for example, to lean more towards burning? When we look at obesity and the basic understanding of it, we do think of it as too much fat. But it's not just a quantity issue, it's also a quality issue. And so some of our current medications help to reduce appetite, thus reducing food intake and causing weight loss and fat loss. But we don't have enough understanding of, is the quality of that fat changing? And so I think that some of our newer agents that are peripherally targeted, ones that might address fat oxidation, lipid metabolism, body composition, preservation of muscle mass over fat mass, will be the next generation of our anti-obesity medications. I think there's a role for combination therapies for one of two reasons. Number one, it just makes sense because when we look at different mechanisms of how our bodies decide hunger levels, fullness, weight, thresholds, there are multiple hormones that are at play. And if we block one hormone or one pathway, for example, our body is savvy enough to activate other pathways to kind of get around that. And we call this counter-regulatory mechanisms. All of that is to sustain the higher weight level or to regain back to an older, higher weight. So number one, I think multiple mechanisms is going to be necessary to address the full complexity of obesity and our weight mechanisms. But number two is also just a reflection of what we do in clinical practice and how we treat any other disease. In diabetes, for example, if one medication does not bring our blood sugars down to normal, we would add a second medication. And oftentimes we like to do different mechanisms to, again, address the different pathways that can contribute to a person's high blood sugar level. So similarly, we like to adopt that framework for obesity, which it too is a chronic medical disease. Weight bias has a significant amount of data behind it showing that it is harmful in so many ways for patients. These patients experience not just external bias, but even their own internal psychological bias because they've been raised in a society that blames them for their weight. And so it is crucial for the medical community to understand that there is data showing this harm and to be intentional about fighting it. Reducing weight bias means acknowledging your own, number one, because we do tend to all have some degree of that, and really putting into place strategies that would reduce that bias for ourselves and for our patients. That means using first-person language, for example, so stating that a person with obesity instead of an obese person is just meeting the standard for any other medical disease. We never say a cancerous person, we say a person with cancer, for example. And it's also important about acknowledging the environment that we work in. Patients with obesity want to feel welcomed and safe whenever they see a medical professional, and that means having the space and medical equipment appropriate to manage and accommodate their conditions. I do want to highlight a nuance on patient adherence here because I think there's some intrinsic bias with that term where we think it might be a problem on the patient's end, that they don't want to adhere to these medications. But really, adherence encompasses so many more factors, and often those factors are systemic challenges. So insurance coverage, costs, barriers to just accessing the medication because of supply shortages. All of these are factors that can reduce a person's adherence to a medication, even when they want to stay on the medication. So I think the challenges that we face today aren't necessarily the ones that are found in a patient's desire or motivation to have these medications. I can tell you from my experience in my patients, they are highly motivated to continue on their medication. They are calling multiple pharmacies a day to see what's in supply. And what we need as a society is a commitment to change the system and to implore our policymakers to help us change that system so that people who need the medication can access the medication. I think that the access and affordability is one of the most crucial questions of our society to answer together. As clinicians, we treat the individual patient in front of us, but because obesity affects more than 40% of our US adult population, this really becomes a population problem, a societal problem. And I think we need to decide together as policymakers, as voters, as individuals with voices to invest in the health of our society. And that will come at a cost, of course, because we've been spending our dollars elsewhere, perhaps in areas that really focus on disease care, sick care, I like to say, instead of actual health care. And this means really refocusing our Congresspeople to look at preventative health, starting with obesity. Treating obesity as a disease is prevention because we are preventing all of its downstream consequences. So recognizing what the cost might be, investing it as a society is a move that we need to decide for ourselves. How do I do more for my patients is what keeps me up at night. I think that as individual clinicians, we can only help one patient at a time, right? And we only have a limited amount of time every day, but if there were a way that I could more broadly help my patients through advocacy, education, information, all of that, then that's what I want to do. Because I do think that as best as we can work together, there's only so much we can do one person at a time. So I think there needs to be broader efforts to compel our policymakers and such to, again, prioritize obesity as a disease and prioritize patients with obesity as people deserving of that care. Something that I'm really excited about, I think, is actually all of the energy in the obesity space. 5 or so years ago, we were kind of a small fringe group, I would say, on the outskirts of the medical system, where trainees, medical students, didn't even know that obesity could be something to specialize in, to train for, to understand better. But I think now more and more people are recognizing it as a real disease and something that we should all be taking seriously from the very beginning as both patients, as medical students, as individuals in our early education. We want to understand the biology of our weight and of our energy mechanisms, because obesity is really just the flip side of that. It's when our energy metabolism goes wrong, and we're finally coming to that understanding. We are finally coming to it as a group, not just as a fringe medical subspecialty, but everyone, policymakers, industry professionals, clinicians, researchers, patient advocates, everyone is on board. This is sort of a message of hope. We've been in this space for several years. Before Ozempic was a hashtag, we have been treating obesity. And that means we've been seeing it change over the years. And I think that from a patient perspective, oftentimes it can feel isolating and frustrating to be started on a medication and then you lose access because of a shortage or insurance coverage. Or you start on a medication and maybe the side effects don't agree with you and you feel like you need to restart all over on a different medication, and maybe there are only 2 medications in your purview that you think are options. And I would say that don't lose hope. There's so many people in the obesity space right now trying to figure this out. And the best thing you can do is to continue speaking to all of the people you trust. And that might be friends, family, certainly pulling in a medical professional whom you trust and bringing your questions to them. It's important to have that guidance as you go through this journey of your medical care, because it really is not a, set it and forget it type of system. It is a long-term relationship, something that we all have to commit to.